transfer center or whoever it is that receives a phone call saying we have a patient we want to send, everybody is in the loop and knowing what our capability is of accepting a patient for ECMO on that day. Something else that we have to make sure that we pay attention to with these patients is setting realistic expectations with the family. ECMO is a support, but it's not a therapy. It's not going to treat the COVID. It will hopefully give time for the body to heal itself. So this is not a therapy, and the family has to be given realistic expectations. Timelines need to be discussed so that patients don't suffer in the end. That is what I have on ECMO.
Thank you. Yeah, I mean, I think it's been really interesting to see how institutions have really gotten stricter and stricter with their criteria, you know, during the pandemic as to whether or not to cannulate patients. You know, a lot of our patients that are with COVID-19, whether they're on the floor or in the ICU, fevers are cyclical and pretty predominant, and it's sometimes very difficult to distinguish, is this just the COVID itself, or is the patient, you know, has a nosocomial infection that's starting to brew? Dr. Griffiths, when would you say is a good point to initiate antibiotics versus targeted therapy, for example, like a GI source? What is your take on antibiotics in the COVID-19 patient?
Thanks for that question. So I think this can get a little tricky, especially if we don't have a good history of the patient, of where they came from. Was it the community, a sniff, an LTAC, that sort of thing? So really getting a good history is important. But I think it's really determining based on clinical criteria, and is the patient declaring themselves to be more infected, so to speak, with potentially a bacterial pneumonia or another bacterial source, such as a UTI or an abdominal source or a wound source, even in your patients with diabetes that might have open wounds. So I think, you know, really waiting for the patient to declare themselves initially. You know, if the patient is receiving steroids and other COVID-19 therapies, are they responding appropriately? And it may take some time to know that. But if they are spiking fevers, if their white count goes up considerably, taking into account that steroids could increase that white count, you know, it's not wrong to empirically start antibiotics or even targeted therapy. If you know that you have an abdominal source, you want to make sure that you're choosing some anaerobic coverage, or, you know, maybe there's something going on in the community and potentially they have a bacterial community-acquired pneumonia, and so starting a, you know, therapy for that as well. But making sure if they've been in the hospital for quite a while, potentially they could have a hospital-acquired pneumonia, or if they've been on the ventilator for a while, a ventilator-associated pneumonia. So really, you know, trying to make sure that we're trying to prevent those things as well. But empirically, starting off with broad spectrum and then de-escalating as you know more from cultures and if the patient is responding appropriately. And for those patients that are just kind of a puzzle and you can't figure them out, you know, call on your infectious disease physicians, get a consult from them. They've been so helpful in helping treat these COVID-19 patients, because they can get pretty complicated when it comes to being in the hospital for 30+ days and the nosocomial infections that are possible within your institution.